Yes, Ines. Okay, I mute. Oh, okay, so the liver is non-cirrhotic, yes. So in this case, one of the important tips, keys, when you find this, that when you don't find the liver cirrhosis, and you find this large lesion, and you find this central scar, and also the younger age. So take care in the MCQ, they like to misleading you with this information, because always when we mention HSC, we think that the background should be cirrhotic, and also the age maybe is not okay. So this patient with fibrolamellar HSC, it come in a younger age, and also the liver is not cirrhotic. Okay, so this is the fibrolamellar. Sure that you, if the practice, you will put metastasis and lymphoma and everything in the differential. But I mean, for the exam, it is very important to put yes. So what do you think about this case, which is not very common, but you can describe that there is in the jejunum something. What is something? It is like micronodularity, okay? So if I mention that the jejunum have micronodularity and this appearance, can you describe?
Hypodense mesenteric lymphadenopathy.
So can you show me which one?
This.
This one, right?
This, yes.
Yes. So low attenuation or low density lymph nodes. It is in the retroperitoneum. So you can think about something called Whipple, which is not common disease, but they mention it in the, yeah. When you think about, you find the small bowel folds, which is thickened, and some micronodularity, and there is mesenteric adenopathy. This triad equals something called Whipple's disease. Okay. Then you will maybe ask it about what is the differential of nodular fold thickening and with lymphadenopathy and low attenuation lymphadenopathy. They have many. Don't forget the most important to mention, lymphoma. It can show you everything, okay? Then this one, which is very common in the exam and also in the practice, when you find this appearance of the liver,
Geographic.
Budd-Chiari. Yeah, Budd-Chiari syndrome. And Budd-Chiari is like obstruction for the flip-flop enhancement, nice. And it is obstruction of which vessels? Of the hepatic, yes, hepatic venous outflow. It can happen in the level of hepatic veins or in the IVC. Then you can see central, then peripheral enhancement, like this appearance, which have different densities, right? It can happen primary or it can happen secondary, which is, we saw it in the practice, more common to be secondary, right? So which one is the most important to search when you find this Budd-Chiari? You should search for HC, yes. Hepatic mets, also it can be, or maybe renal mets. Yeah. Maybe some hypercoagulable status. Okay. So this Budd-Chiari is very important in the exam, especially when you find what is this? What this loop? The
Caudate.
Yes, caudate loop.
Caudate enlarged.
Is, yeah, enlarged and hypertrophied, and it is normally preserved. Why is preserved? Because it takes directly from perfect mesenteric veins. Yes. So isolated supply, nice, perfect. So this different drainage. This is what you mentioned, IBAD, yeah, that spider web in
spider web appearance on angio.
In angiography, yes. So this is the typical appearance in angiography. When you find like network of vessels, of collateral vessels, then you are going with Budd-Chiari syndrome. Okay. This is what is called flob appearance. Don't forget that the caudate lobe is spared. Okay? This case, what do you think about it?
Nutmeg liver.
Nutmeg liver, nice. So there is congestion and search for the cause of congestion. Don't forget that there is ascites. So this patient is non-compensated.
Cirrhosis.
Yeah, so this patient is not compensated. Then he presents
Dilated IVC.
ascites. Perfect. So what we can imagine here that there is IVC dilatation, then search for the cause, and one of the common causes, that's congestive heart failure. Nice, IBAD. Congestion, Nermine, nice. So hepatic congestion, veno-occlusive disease, transient hepatic. So this is what's called cardiac cirrhosis, nutmeg liver, and sometimes you can see the contrast reflected or reversed here from the cardiac side, and also there is cardiomegaly if you see the cuts in the heart. As we mentioned, that you can see some ascites, some pleural sometimes. Okay, this is what's called cardiac cirrhosis. Okay, let's shift to this case, which is not very easy, but you can imagine that there is something going in the mesentery here. Maybe, but I agree with you that there is this window is not very good window, but yes, there is something with the thickening in the bowel. This is differential misty mesentery. Nice to mention, misty mesentery. So when you find this mesentery soft tissue, you will think about any tumor or any metastasis or any peritoneal disease. But also don't forget to ask about trauma. If this patient have like bowel injury, then sometimes you can have this appearance, which is mesenteric hematoma. Okay. Then you will be asked to do CT to evaluate if this patient, with contrast to evaluate if this patient have any other injuries. Yes. This one is more easier, yes. So you find something in the, like, in the wall here, yes, of the gastric intramural. Yes, I agree with you that you will think about something like GIST.
Yeah.
Yeah. It is in the greater curvature. So one of the differential myths, ectopic and ectopic pancreas, nice, GIST, very nice, adenoma and polyp. So this is what's called solitary gastric mass. They make differential for if it is more than 2 centimeters or it is less than 2 centimeters. So if it is more than 2 centimeters, you will think about cancer, metastasis, GIST, adenoma, anything like a tumor which have growth. And you can add also cyst like duplication cyst, but not in this case. If it is less than, and this amplification is important to mention when you find this central amplification. Yeah, nice. So you will mention GIST, lipoma, neurofibroma, hemangioma. Okay. And melanoma MITS. Nice. So target lesion from melanoma, MITS. Yeah. Breast, lung, also carcinoid maybe. Okay. So this is what is called solitary gastric mass, less than 2 centimeters. When you find intramural gastric mass with central amplification, so think about this, but don't forget the ectopic pancreatic tissue, which is this case. Okay? Let's have a look again. Ectopic pancreatic tissue with central amplification. Okay. let's go to another case which is not easy, but you can see that this is the stomach, right? And this is a small bowel, and here there is communication. So this is what is called Nermin, yes, gastro
Fistula.
fistula. So if you find this, nice that you mentioned that you will ask about operation if this patient underwent any operation. Yes. And other causes can happen. Crohn's, nice. TB also can make fistulas. And maybe
CA.
yes.
CA.
What? Sorry.
CA carcinoma.
Carcinoma. Perfect. Gastric carcinoma. So gastric carcinoma, yes, and also colonic carcinoma, right? You mentioned colonic, transverse colon, or maybe in the splenic flexure, right? Because it is near this site. So this is what's called gastroenteric fistula. This one is like here is very obvious one. All the chest that will check the retrocardiac region, and I think there is one short question in the one of the EDIR, and they mentioned this one. Okay, I can just stop for a few minutes and tell you about the some reviews come to me from some colleagues that they pass the EDIR recently, very recently, from maybe 2 weeks. And they mentioned that the exam was like, to be honest, it was for him like difficult, okay? But the most important, it was the long question, as we mentioned before. The long question was the most important one. They mentioned also that the short questions, as general, it was very easy, wasn't difficult. The long cases was much, and the time very, very limited. As I mentioned before, you have very limited time, especially use typing methods. So the typing takes already time from you to type and to make description. So try to find the keywords as we do here, that when you see a picture or case, try just to mention the most important description, okay? So don't waste your time to write, for example, if the patient have colonic carcinoma and, for example, have liver mets, and there is some incidental finding like this degenerative changes in the spine, or maybe have some bone islands. Okay, maybe if you have time, describe it lately or in the. But to be honest, most of the time you don't have. So mention the positive, the most important to mention the positive things, and mention if there is, for example, for the case we show you from while ulcerative colitis, and this patient, for example, should mention that there is free air in the abdomen, or there is no free air in the abdomen, because this is most important, negative. So you should mention that no free air clearly, okay? Don't waste your time to mention incidental finding which is not related to the disease. Okay, mention it if it is related, but don't waste your time. Also the differential, try to mention differential if it is typing. Sometimes they give you just to choose, like to click, like here to click just like this, or sometimes you should to type. When you type in the differential, try to write what is more related. And yeah, the exam is about 90 minutes for each session. So you have 3 sessions. The first session is for MCQ, second session for the short question, third session for the long questions. So you have 90 minutes, about 1.5 hours for everyone, for every session, and you have 10 minutes break between. The exam were recorded by cameras everywhere, and you have maybe some local commission or committee that they follow you to not have anything like error, or maybe they can help you if you have something. But yeah, you write your name and your email, sorry, and your I think your name, yeah, it was your name and your password as they send you in your email, and when you log in, the exam start, and you have few minutes, sorry, I have 90 minutes to finish each session. Okay, so the until now we have all who call me who was passed the exam. So alhamdulillah, we most of the who I know, he passed the exam clearly, and he was also with us in this session or maybe other sessions, but all it was fine. Okay, let's continue. So this one is hiatus hernia clear. This is with fluid level. What other differential you should mention if they ask you about differential?
Cyst.
Abscess, perfect. So when you find fluid level, it is hiatus hernia or it is abscess. And there is other differential, maybe some complicated cysts and so on, but yes. So this one, it is hiatus hernia. Another type of hiatus hernia, which is the, which type, this one? This gastroesophageal junction?
Paraesophageal.
Paraesophageal, perfect. So this one is paraesophageal. Nice, Nermin, yes. Let's go to another one. So this one is not very easy, but maybe you can imagine that the gastric position is not in normal orientation, yes? So you can imagine that the greater curvature is superior and the lesser curvature is inferior, right? So this is what is called...
This is organoaxial.
I bet, organoaxial, yes. And ala, yeah. So this is organoaxial volvulus. And there is another type. What is the other type of the volvulus in the gastric region?
Mesenteroaxial.
Mesenteroaxial, yes. So which one is common in the old age? And which one is more common? Yes. And it happened with...
Organo in adults.
Yes, organo, yes.
Mesenteroaxial more in pediatric age group.
Yes. So organoaxial in old, and this one, what we have, it is the organoaxial. So this is come here, and this is more common. And you can see that the greater curvature is upward and the lesser curvature is downward. So this is what is called organoaxial volvulus. So another case, they mentioned that, yes, if you follow the stomach and the antrum, then what happened here? Yes, there is something here in the, which part should be here? Yeah, the duodenum, perfect, Marwa. So I will go and see what in the CT could be here. So this is what is called intramural hematoma. Yes, intramural hematoma. And there is some MCQ question about the mechanism of injury in this patient, duodenal hematoma. Anyone know about this? Yes?
Seat belt.
Seat belt,
Trauma.
perfect. Seat belt trauma. Blunt trauma, yes. Blunt trauma, perfect, yeah. And more often found in the pediatric. Nice. Who mentioned, yes, NAI, yes, perfect. So this one, it have the abuse, child abuse, so they like it. That's why when you find this, sorry, where we go? Sorry. When you find this appearance, check maybe if he's in the pediatric age group, this patient have abuse. Okay. Also, the differential will be sure that tumor, but in this case, maybe it's easy. Yes, it is easy. Okay, let's go to this case. So what happened here? Yeah. They mentioned that there is blind outbouching in the distal ileum. So if I mention to you like this, what pouch, which is blind, happen in the Meckel's, Marwa, nice. Meckel's diverticulum, and this is nice appearance in the CT, how it looked like. So Meckel's diverticulum, and if I show you this one, I think now in the technetium, you can see that this young child have accumulation of technetium. What does it mean this? What does it mean?
The same as gastric mucosa.
Sorry, it have
the uptake.
Yeah. So what
the uptake is the same as gastric mucosa.
Perfect. So there is ectopic gastric mucosa, yes, in the Meckel's diverticulum. So this patient have what is called GIT bleeding, yes. It's very difficult, not very easy to be honest, that to diagnose it in CT, but in the location, which is its anti-mesenteric border, it can help you to differentiate it from the, for example, what is near here will be the appendix. So the appendix, for example, come from the cecum, but this one come from the small bowel, yes, from the terminal ileum. Also the rule of two, you can read that it happened in 2% and 2 feet, 2 inches, and so on, maybe. But this anti-mesenteric border, it is one of the important that you should mean. When you suspect it, search for complication, which is more important. Bleeding, obstruction from the intersusception, maybe diverticulitis. That's why it mimic appendicitis, and maybe perforation. And finally, it can show you transformation to neoplasm. Okay. Again, when you find the stricture, then try to describe it in barium terms. So which one is this? Is it, which side you like to describe it? Yeah, this one, single contrast barium enema. There is, this one should be the splenic fracture. So we are in the colon, splenic fracture, and there is, yes, this is watershed area in the splenic fracture. Nice, Ala. I don't know Ala or Ala because all are mixed, but okay. Ischemic cause, watershed, Marwa, ischemic, perfect. One of the most important to mention that it could be ischemic colitis. And this appearance, they like to say that is thumb printing. So please try to, when you see this stricture with this appearance and you suspect that is ischemic, Ala, okay. So Ala, you will mention that is thumb printing, because this is the submucosal edema or hemorrhage. Yes, elderly patient with heart disease, this is the type of the patient. So in the MCQ, if it comes to you, elderly patient with heart disease and thumb printing, it is equal to ischemic colitis, okay? Elderly patient. The location is very important because this is the watershed area. Also hypoperfusion more than thrombus. It happened the elderly. They like it with this thumb printing. Sometimes show you what we mentioned before with pneumatosis intestinalis and portal vein gas. This one, it is like a description for the biliary ducts, which show you some cholangiographic finding of what? They mention one description which is important to know, something called abnormal arborization of the intrahepatic biliary ducts. It is like cholangiographic, yes. So what is equal? It is equal to, there is abnormal arborization of intrahepatic biliary ducts, and there is some strictures and some dilatation affecting the left hepatic. So this one, it is primary sclerosing cholangitis. What is primary sclerosing cholangitis? Yes. Men or women the type of patient, man or woman?
Woman.
No, no. Male, yeah, yeah. So the male is here is more affected. So this is nice new for you, and also associated with ulcerative colitis. Okay, yeah. So when you find this ulcerative colitis, there is many association. They mentioned that it is something called IgG4, IgG4 disease. What is IgG4 disease? Riedels, thyroiditis, Crohn's, retroperitoneal, mediastinal fibrosis. Yeah. So this is like disease which have many association everywhere. We mentioned
Orbital pseudotumor.
Yeah. So what? Sorry. Yeah.
In IgG, there's also orbital pseudotumor.
Yeah, and orbital pseudotumor. Perfect. Yes. So when you find this appearance, you are going with primary sclerosing, which is progressive inflammatory process, more common in the men. That's good news. And ulcerative colitis and other associations. This is good description to know which this beaded appearance is very useful when you mention it. Okay. So as you mentioned, Ala, that AIDS, it will be the important differential diagnosis, something called recurrent biogenic cholangitis, maybe post chemoembolization, post TACE, and post also liver transplant. What happened? Hepatic artery thrombosis. Okay. So for example, primary sclerosing cholangitis complicated with cholangiocarcinoma, which is, yeah, 15% in the cases. Okay. Here, this patient, very similar with beaded appearance, irregular strictures. Yes. So this is what's called AIDS cholangiopathy. Okay. There is another one, is called bacterial cholangitis. They mentioned that there is some secular, yeah, communication with the biliary system. Yeah. And there is some filling defects. Okay. Okay. So what do you think about this case? Yes. What is your keywords? Let's try to train for the exam keywords. Yeah. Calcification, yes. So calcification, you can see here calcification clearly. So in the checklist of the X-ray of the abdomen, you'll find the calcifications. And if this patient did ERCP, you can see that there is some irregular dilatation of the main pancreatic duct and the side branches. Yes, along the expected site or presumed site of the pancreas. So with pancreatic atrophy, Marwa-S, stable calcification, I agree. All this give you this appearance. I see that everyone is familiar with the GI. That's really good news because we can go more faster. And I see that you are very, very helpful and useful in this. Okay, so nice. Also, the dilatation of the pancreatic duct in CT is much, much more. And with the atrophy of the pancreas, yes. So what is the differential?
Chronic pancreatitis.
Yes, chronic pancreatitis, maybe sometimes with alcohol or gallstones, so search for either, yes, and the calcification is the key in this case. Sometimes it can have pseudocyst we mentioned in the previous case. Okay. So what do you think about this one? Where is the pathology?
Distal common bile duct stone.
Okay, nice. So when you find this eye, I mentioned that is eye. No, no nervine, no. The annular pancreas is a bit different. You imagine it when you find another tissue of pancreas here. So it is filling defect. So it is, yeah, it is stone, choledocholithiasis. Maybe you mentioned it, yes, Ala. So in two section is a bit difficult. I know, but yeah, choledocholithiasis is one of the good things. bile duct dilatation, as we see here, and you can find this filling defect and also the dependent location. And in the MRCP, this sign called
Crescent sign.
crescent sign. Perfect. This is what's called choledocholithiasis. And in the ultrasound, you can see what happened here, the posterior aquastic shadowing, right? Posterior aquastic shadowing. And in the ERCP, you can see again the filling defect. No problem, Nermeen, it's fine. Everything is fine. I understand you, so it's fine. Okay, so again, ERCP, and you find the stricture. Is it benign looking stricture or malignant looking stricture? What?
Malignant.
Malignant. Why
Malignant.
malignant? Because it,
Sign.
perfect. Irregular, and there's stricture which is irregular. So the most common cause for this, what it will be, like if we, yeah, it is cholangiocarcinoma, one of the most important things to consider in the biliary. Okay. So for example, let's have a look in this stricture. Is it benign or malignant?
Benign.
Yeah. Benign. So this is post ERCP, sorry, post cholecystectomy, yes. And what do you think about this one? Is it benign or malignant?
Benign.
Benign. Okay. No. No. So this one look like malignant because it is abrupt change. Abrupt change. It's not smooth. It's not smooth. Okay. So it is going with, yeah, more malignant. Yeah. So when you find the biliary stricture, try to characterize it is abrupt change or irregular change, or there is marked obstruction, then you are going for malignancy. Okay. If it is tapered and it's like more going with the smooth appearance, so go for benign. Okay. You agree? Okay. Everyone agree? Okay. If everyone agree, we'll be happy. Okay, so what do you think about differential of biliary stricture? You can go for the list of inflammatory, neoplastic, trauma, and maybe extrinsic, and so on. You have many good lists. Don't forget cholangio and pancreatic, which is something common, and in the inflammatory pancreatitis. It can happen with many things we mentioned already. Okay. This is what is called, when he did ERCP, you find like two ducts dilated. So this is what's called double duct sign, which is characteristic, or maybe is like, yeah, double duct sign, which is more common to search for what is happening in the head of pancreas. There's mass. Yes, there is mass here.
Pancreatic head.
Yeah, pancreatic
Mass.
cancer or adenocarcinoma. So when you mention adenocarcinoma or pancreatic head mass, and it comes to you as a long case, the most important to comment what it could be. The most important when you find pancreatic.
If it is operable or not.
Perfect. So you should mention that it is operable or not. Depend on what? Depend in the, what is the most important thing that to mention and to comment in your practice, or even in the exam, to comment on what?
Superior mesenteric artery, celiac artery involvement.
The artery and vein. Don't forget this, because as we mentioned, this is the landmark for you. So don't forget to make, is it encased? Because the superior mesenteric artery, if it is invaded or encased, so you are going that it will be inoperable. Okay. And also to comment in the superior mesenteric vein, ensure that it reaches aortic surface. You should comment in the aortic surface, and if there is any other organs. Okay. So if we can try to remember the inoperability, how, if it is more than 5 centimeters, right? if there is, for example, duodenal invasion or any organ invasion surrounding, the most important, as we mentioned, the SMA arterial invasion and also the celiac. So how to mention that? Yes, perfect. I bet more than 180. If you find this one more than the circumferential thickening around the artery more than 180 degree, so it is going to be encased, and this is what is, yes, sure that if it is occluded, this is more and more. Then search for metastasis. So the most common metastasis will be in the liver, so search for liver metastasis. And finally, look for the black. What is the black? The black. What is the black? The black? The fat. So look in the fat and look for peritoneal carcinomatosis. Okay? So the pancreatic head cancer, they like it in the long exam. It comes to you in the long exam, and sure that the most important to focus in the keywords of the operability. Yes. So what you should mention, this is the most important. And don't forget the metastasis, because if it is metastatic or you have metastatic lymphadenopathy, so it is inoperable, okay? And peritoneal carcinomatosis, plus or minus if there is any venous invasion like portal vein or SMB. So the other mirror of pancreatic cancer, it is the, yes, the HSCC, yeah. So when you find the liver cirrhosis, the most common tumor or focal lesion, or the type of tumor that happen in the liver, it will be hepatocellular carcinoma, which is the typical for the liver cirrhosis. Okay, so when you find liver cirrhosis, then nice, Marwa, you will search for the vascular affection. What the most important to mention? The portal vein. Yes, so mention that the portal vein is affected in this case. Don't forget. Yes, and nice. And search for other criteria of cirrhosis. As we mentioned, you will see the what? The ascites, and if this patient has splenomegaly and hypertension. Yes, perfect. Signs of cirrhosis, I agree with you that maybe is not very typical here. That's because it's just one image, but the nodularity, sure, that is not very smooth in this case. So sure that have cirrhosis, and also the focal lesion and the encasement portal vein, the hypertrophy of the caudate lobe, the left lobe, not very. I agree with you, but to be honest, there is some cirrhosis in this case, at least for this image what we have. Okay, but not very advanced cirrhosis here. So portal vein thrombosis, when you find it, search for the most common cause, which is HSC, and the other causes we mentioned it already with Budd-Chiari, right? Yes, the same causes probably. Okay. And one of the common complications that happen after portal vein thrombosis, what is called cavernous transformation. Yes. This is the differential when you find like hypodense liver when in the background of healthy liver. The liver, it look like a healthy. So when you find like this lesion, I agree with you that the first thing that describe first, is it cystic or solid? But if you go that this one is solid, so which differential you are going with?